Okay, this video is the newsletter for this month of October 2023. The newsletter topic is what causes insulin resistance and diabetes, or how to prevent diabetes. I don't know how to use my program well enough to show my picture simultaneously in video while I'm doing the video, so as soon as I get that fixed, I'll do it, but until then I can't. Okay, so the big deal about diabetes is what causes diabetes. For any disease, you want to know what causes it, because once you know what causes it, you could avoid the thing that causes it, and quite often avoiding the cause is the same way you treat the disease. So for diabetes, the number one cause of diabetes is exceeding excessive amounts of dietary fat, especially saturated fat. One author believes that the reason sat fat is more likely to cause diabetes is because the lack of a double bond means that it sends more electron carriers to the electron transport chain. It makes an extra FADH2. Okay, be that as it may, all types of fat increase the risk of diabetes, but especially saturated fat. When a person reduces their dietary fat to below 10% of calories, they often get dramatically improved insulin sensitivity. Roy Taylor, who won the Banting Award in 2012 as best diabetes researcher in the world, says that diabetes is a simple condition of fat excess, and he had a lot of patients reverse their disease by minimizing their dietary fat. However, I think there's more to it than that. That's obviously the most important thing. It is. But there's other things that contribute. Okay, Tetsumori Yamashima in his papers wrote that hydroxynonenal, a toxic aldehyde from omega-6 cooking oils, was causing damage, destruction, apoptosis over a gradual process over decades of the pancreas beta cells. Pancreas beta cells are the ones that make the insulin. So that helps explain why some diabetics, they're skinny. I've seen some persons from India, they're skinny, but they got diabetes. And you can also have something called diabetes 1.5, an intermediate type of diabetes. So diabetes 1 is the classical child onset diabetes, and that's the one thought primarily due to autoantibodies, especially associated with dairy products, where there's cross-reactivity between the antigen from the dairy proteins and the pancreas, okay? T. Colin Campbell writes a lot about that, as does Dr. McDougall. All right, so anyways, another thing that'll cause increased risk of diabetes when there's increased intracellular calcium. And there's a bunch of things that'll increase intracellular. That means cytoplasm calcium. That would be excessive dietary sodium because it dissipates the plasma membrane gradients. Usually you got a big sodium electrochemical gradient, and when you dissipate that, you lower it, then you're less able to run cells efficiently, and that in the long run leads to insulin resistance and diabetes. Also, if you're short of potassium and magnesium. So the typical American eats too much sodium and not enough potassium and magnesium because potassium and magnesium come from plants. So eat more plants, don't add salt, and that will help improve insulin sensitivity. Increased cytoplasm calcium caused by dietary excess of vitamin D or of calcium. There's a paper on that. I don't know how big that one is, but certainly, there's been a lot of work to show that calcium supplementation is overrated. And a lot of people, myself included, think vitamin D supplementation is overrated. Okay, dietary excess of sodium increases. By the way, I just get my vitamin D from going in the sun. I don't take anything. Dietary excess of sodium increases insulin resistance by increasing cytoplasm calcium. Yeah, we already talked about that. Okay, here's a new thing. Excessive dietary industrial fructose, like high fructose corn syrup, will increase sodium absorption in the gut. So that's a problem. Plus, excessive fructose leads to increased production of uric acid from the liver because fructose is metabolized very different than glucose. Glucose metabolism is tightly regulated. It's the energy of life. Whereas fructose, when it comes in a bolus, like from a sweetened processed food, it enters glycolysis past the 6-carbon phase. It enters at the 3-carbon phase. And thus it bypasses all the regulatory steps, especially the phosphofructokinase step. And what that means is the liver really can't control the rate at which it metabolizes fructose. It just comes in as a bolus from some processed food like a bogus energy drink, and then a lot of it just gets converted into fat in the liver. You get a fatty liver. Okay, and also in the process, you're going to produce increased uric acid. And the uric acid is an inhibitor of endothelial nitric oxide. So you don't get as good a vasodilation after eating a meal with a lot of fructose in it in your muscles. And that means the glucose can't get access to parts of the muscle, so it can't be stored as glycogen. So normally, after eating a meal, 80% of your glucose gets stored in your skeletal muscles as glycogen. When you can't open up those muscle vessels because of uric acid related vasoconstriction, then your blood glucose stays elevated a prolonged amount of time. And so that's a form of insulin resistance. Okay, excessive psychological stress because of the increased cortisol and catecholamines. Those are the hormones of stress. And you get the same thing with stress equivalents, which means like lack of sleep or caffeine and corticosteroid medications. All right, being sedentary. Because normally when you exercise, the glucose type 4 transporters, the same ones that are activated by insulin, they also just move to the plasma membrane due to the exercise, okay? That's a way the skeletal muscle can get increased glucose coming into it. And the point is, if you exercise, you get that benefit. If you don't exercise, you don't get it. So exercise is very, very beneficial to the diabetics. Here's the references for these papers that I'm referring to down here. Okay. Other things that'll do it. Excessive estrogenic chemicals like BPA and the phthalates, for example. I got the references down here, can lead to obesity and insulin resistance, and they're associated with increased risk of diabetes. Estrogenic chemicals are also often associated with decreased neuronal function, decreased thyroid function. They're much worse than is widely recognized. Atrazine in particular is quite bad. That's the herbicide sprayed on non-organic corn. Glyphosate is the active ingredient in this stuff here. The rounding up, and it's sprayed on non-organic soy and some other crops. It increases the risk of fatty liver. References for that are down below. High fructose corn syrup increases the risk of fatty liver. We kind of talked about that already. Excessive alcohol is very similar. Increases the risk of fatty liver. Excess alcohol is even worse. It's got secondary toxicities through toxic aldehydes like HNE potentially. Dairy, we talked about dairy being increasing the risk of type 1 and type 2. What I was meaning to refer to earlier is somebody who's getting direct toxicity to the pancreas beta cells, like from aluminum or from the omega-6 cooking oils and their byproduct metabolite, hydroxynonenal. They can get a picture that's a little bit like type 1. So they might have a double picture, a mixed picture of autoimmune component type 1-like and the same old high-fat toxin type 2 type and end up with something in the middle. But they're more at risk to become insulin dependent. You know, type 2 diabetic, if they get their act together soon enough, they can often reverse the disease completely. And aluminum's in a lot of things. It's in the tap water, it's in deodorants, it's in other personal care products, it's an anti-caking thing in salt. Okay, artificial sweeteners increase insulin resistance. They sort of trick your taste buds. Your taste buds think you're ingesting sugar. They send a message to the pancreas and it starts popping out insulin, but then there's no sugar. So the receptors start becoming resistant to it. Excessive dietary animal protein increases insulin resistance because it's activating mTOR and it sort of sets the stage for fat storage, and it just throws off your insulin a bit. These are not the main things. The main thing is the dietary fat. But again, if I was having trouble getting my diabetes and my weight under control, I would try to optimize all this stuff. PFOA is perfluorooctanoic acid. That's typically your nonstick cookware and some other nonstick surfaces like the screen of your cell phone. So I would rinse your hands off after using your phone before you eat. POFA in rats causes pancreatic beta cell apoptosis. That means death of those cells. Increased reactive oxygen species, increased mitochondrial superoxide, that's a free radical, and pro-inflammatory cytokines, so it's bad. Mitochondrial inhibitors and SERC inhibitors, okay, because SERC inhibitors are essentially like mitochondrial inhibitors. Mitochondrial inhibitors is kind of like what fat does. The reason fat inhibits inhibits insulin resistance, it inhibits the electron transport, like complex 3, makes it reverse, okay, and that causes a whole cascade of related events because metabolism is disrupted, and then the skeletal muscle can't handle the glucose, or can't handle the fat, the postprandial fat in your blood, so you end up with insulin resistance. And what I'm saying is the mitochondrial inhibition due to other things is very much like the effect of SAT fat on the mitochondria. Okay, what prevents type 2 diabetes? Avoid the things that cause insulin resistance. Like we said, eat plants so you get your potassium and your magnesium. Don't add salt so you avoid the high sodium. Avoid all your fats as much as you can. You'll get some fats just by eating plant foods and from the fiber. You don't need to worry about it. It's impossible to be too low in fats, okay, on any type of naturally chosen diet. Okay, and walk a lot or do whatever type of exercise you like. Okay, what's the best introduction to learning about diabetes? I think my introduction to diabetes lectures are pretty good. There's a lot of other internet websites where they're good at teaching you about diabetes and stuff. Dr. Neil Bernard has a good lecture on it. Bobby Bitterow and Cyrus Kumbada over at Mastering Diabetes have good videos on it. They're both type 1 diabetics who now eat a diet that's almost fruitarian. Dr. McDougall's got a good lecture on it. Neil Bernard's got a good lecture on it. Michael Greger's got some good lectures on diabetes. So it's all there. Out of all of them, though, I think I go by far into the most detail. My book that I wrote, How to Reduce the Risk of Chronic Disease, I go into a lot of detail about, the complications of it, the pathophysiology. And then, like, one of the most useful things to know is when you reverse your atherosclerosis risk factors, you'll decrease ischemia of the nerves, and you'll often potentially get a significant improvement in diabetic neuropathy, for example. And then Walter Kempner, MD, he had shown with his rice diet, a lot of patients reversed or certainly improved their diabetic retinopathy, for example. Okay, let's see. Who are the best researchers in the world? Well, we talked about these three guys: Michael Brownlee, Banting 2004, Roy Taylor, Banting 2012, and Gerald Shulman, Banting 2018. Sort of like the best researchers in the world on diabetes. Shulman's got a nice video on YouTube. Roy Taylor's got videos on YouTube. Brownlee, you can get him at the ADA.org site, American Diabetic Association.org site, his paper and his video. Okay, what is the benefit now? I'm going to show you a sort of a conceptual staging system that I got from looking at the work of all the previous researchers and especially at Gerald Shulman, and I just organize it into what I would call a conceptual staging system to help people understand. Because I've seen most diabetic patients and their families, they just have zero idea what's going on. The patients and the families typically say, he's got it under control, he's got it under control, meaning that he takes his insulin every day. But you can really do a lot better than that. The standard guidelines are made for people who are not able to cooperate in their care or only very little. So let me close my door because my dogs make a lot of noise. Okay, sorry about that. And most people, they're just not that motivated. I've had lots of diabetics tell me they'd rather, die than stop eating meat or whatever. So that's a frustrating thing. And I think a lot of times, too, as they get sicker, they lose insight. And they're not able to help themselves. Okay, here is, we talked about all that. What about toxins? Well, I talked about some of the toxins. What about the estrogenics? Yeah, I talked about the estrogenics. Okay, some of the diagnostic tests. A normal hemoglobin A1C is 5.5 or less. Normal fasting blood sugar is less than 100. Prediabetes is diagnosed when their hemoglobin A1C is 5.6 to 6.4. Also with a fasting blood sugar of 100 to 126. Okay, now when is full-blown diabetes diagnosed? When their fasting blood sugar is over 126, or their hemoglobin A1C is greater than 6.5, or they have an oral glucose tolerance test greater than 200. A hemoglobin A1C greater than 7 is suggestive that the diabetes is relatively poorly controlled. What are glucose transporters? Glucose type 1 is a transporter for the blood-brain barrier. Glucose type 3 is a glucose transporter in the neurons of the brain, and they don't require insulin. The most important one for us to care about, though, is glucose type 4. Glucose type 4 transporters are present in your skeletal muscles, and they are insulin dependent, and that's where most of your insulin is supposed to go after you eat a meal. There's also glucose type 4 transporters in your hippocampus, your memory center. And if you got insulin resistance, you don't just have insulin resistance in the periphery. You've also got it in your hippocampus. And that's a real problem because with insulin resistance, you can't get enough glucose into those neurons when they're active. And that can end up contributing to ending up in apoptosis, brain cell death, and make you stupider. Okay, what happens to metabolism with the keto paleo diet? All that high fat, it's a disaster. It's very stupid. And even if they can transiently control their blood glucose level, they're still insulin resistant. So it's a very stupid way to go. I don't recommend it. Those high fat diets, I think they're a disaster for health. Oh, okay, how come more doctors don't know about this? Like I said, doctors are trained to match the ill to the pill and send a bill. They're not trained to understand disease or what causes disease. As bizarre as that sounds, it's true. You should think of medical schools like a trade school where doctors learn how to prescribe drugs. That's pretty much what med school is. Okay, I did talk briefly on that last page a little bit about internal medicine talks. You know, they really need more pictures. They show too many tables of data and they're kind of boring. A good radiology talk's a lot more interesting with a lot more pictures. Well, that was because some endocrinologists had invited me to talk to their fellows about diabetes, but then I kept blabbing on too much and they realized that I knew far more about it than they did and they were embarrassed, so they rescinded their invitation. They just never followed up on it. Okay, and that's what I meant, you know, if there was a reward for curing the patient, all this stuff would become common knowledge very quickly, but because there isn't, there's actually a major punishment if the patient gets better, then they don't buy drugs anymore. Okay, so what we're in is a Nash equilibrium. A Nash equilibrium is a self-sustaining system, and it never changes because no one has a significant advantage to changing it. Okay, so let's go through the staging system, a conceptual staging system for diabetes. Okay, so what this is about is where the fat goes, you know, and Dr. Shulman's referred to it sometimes as ectopic fat theory. Roy Taylor talks about everybody having a personal fat threshold. So personal fat threshold means that a person can only store so much fat. Some people can store a lot and they don't become diabetic till they weigh 300 pounds. Other people, if they're just 30 pounds overweight, they become diabetic. And some of it has to relate to how much subcutaneous fat they have, for example. So anyways, the first spot you accumulate fat is just sort of in your fat cells, in your fat tissues around your body. A diabetic is somebody who's too fat for their body. Okay, the next thing we're going to talk about is where's the next spot where fat tends to accumulate. It'll start accumulating in the muscles, like the skeletal muscles. And that accumulation of fat in the skeletal muscles is what Gerald Shulman, you know, the MD PhD guy over at Yale, showed with nuclear magnetic resonance spectroscopy, that accumulation of fat, and they called intramyocellular lipid, was the first detectable finding of insulin resistance. And did a whole bunch of tests to confirm that. And it's quite brilliant work. Another question is, well, why does the fat get into the cell so easily? It's because it can go across the plasma membrane of a skeletal muscle cell using what's called the flip-flop maneuver. And we're just not designed to eat these high amounts of fat. So I gave a whole lecture on that. And that's a pretty important thing to know about fat. Basically, you're screwed unless you reduce dietary fat, because it's just going to get across that plasma membrane in the skeletal muscle. There's nothing you can do about it. Mitochondrial transport becomes overwhelmed when a person eats a large amount of fat, especially saturated fat, and it reverses at the level of complex 3. And then that leads to a backup of the preceding pathways like Krebs cycle and glycolysis. And then this creates a whole cascade of events, including the production of advanced glycation end products like methylglyoxal, and we don't need to get into all these details. I've made a bunch of longer lectures with all the picture slides, so you might find those helpful. But the next big thing is after you've accumulated fat in the skeletal muscle, and that causes postprandial hyperglycemia, meaning it causes elevated blood glucose after you eat. Prandial is eating. Okay, so what's stage 3 of diabetes? And then you start accumulating the fat in the liver. Fat in the liver causes a whole different series of events. When the fat accumulates in the liver, the liver becomes unable to accurately sense blood glucose, and it keeps on pushing glucose into the blood through gluconeogenesis. So when you have skeletal muscle fat accumulation, you get postprandial hyperglycemia. So that means after eating, high blood glucose level. But once you've got a significant amount of fatty liver, you start getting high blood glucose even while you're fasting. Okay. Fatty liver is super common. Super common. I see it all day long, every day. Okay, so what happens then is the fat keeps accumulating in the liver. Eventually, you start getting fat accumulated in the pancreas. With a type 2 diabetic, insulin dependent, it's pretty routine on a CAT scan of the abdomen to see fatty replacement of the pancreatic head. So, and then the next thing that starts happening is you start getting more so-called fatty arteries contributing to your atherosclerosis. You get this whole microvasculopathy. Part of where that comes from is that The skeletal muscles have glucose type 4 transporters, meaning that they only take up the glucose they need in the setting of insulin. There's other cells, like your endothelial cells that line your arteries. They don't have glucose type 4 transporters. They just take up glucose based on how much there is in the blood. So if there's high blood glucose levels, hyperglycemia, they will end up taking up too much glucose. And that'll cause endothelial dysfunction and a microvasculopathy. Diabetic microvasculopathy is really bad because it occurs in the little vessel. It occurs everywhere, but it especially occurs in the little vessels of the foot. And there's no outflow, like meaning that if you have a bypass graft, there's nothing to plug it into distally. So it's a screwed situation. You just have to amputate the toes. Every major hospital in the whole Western world has a bunch of toe amputations every day for diabetics. Okay, then you start getting diabetic problems in the eyes, diabetic retinopathy, and the same diabetics, they're usually hypertensive, they're usually obese, so they also get hypertensive retinopathy. And it's the same patients that have increased risk of cataracts and glaucoma and age-related macular degeneration. So it's common for them to go blind. They often just die, though, of heart disease before anything else. That's why, even though it causes kidney failure, they'll often just be, dead from a myocardial infarction first. And then the effects start becoming more and more noticeable in the brain. I can tell you the vast majority of my diabetic patients over 55 years of age are cognitively slow. It's rather obvious. And, like I said, then they often get myocardial infarction. So the fat's sort of accumulating in different locations. And so what you want to do is decrease your dietary fat, lose weight. And you'll often lose a lot of that fat pretty early from the liver. And so you can rapidly get an improvement in blood glucose control and an improvement in insulin sensitivity. So one of the things to get from this lecture is diabetes is a disease primarily of fat metabolism, but everybody calls it sugar diabetes and they think there's a problem with carbohydrates. And that's relevant because a lot of diabetics are told not to eat starches, but starches are good for them. And fruit can be good for them too. Something that's got enough fiber is not super sweet. Let's see. And Dr. Schulman likes to refer to this as ectopic fat theory, this idea of too much fat in the wrong places, that fat really only belongs in your fat tissue for the most part, and it shouldn't be going in all these other locations. Okay, what about bariatric surgery? Yeah, you can get pretty good results from bariatric surgery, and Garth Davis has talked about this. The only thing is, what Garth Davis, for example, notices the patients need to also improve their diet, because if they don't improve their diet, even with the bariatric surgery, after a couple of years, their weight's going to start drifting back up again. So they got to change the diet if they want to long-term consistently keep themselves from becoming obese and diabetic. Okay, diabetes increases your risk of cancer. It's got a lot of things going on with it that associate with increased ILGF, increased mTOR. Obesity is a tumor promoter, and they eat meat, most of them, and that's a tumor promoter. So anyways, I hope this lecture was helpful. The key point was, yeah, as you know, fat's the main risk factor, especially saturated fat, but those other things are risk factors too. Too much dietary sodium, not enough dietary magnesium and potassium, which is easily to fix. Just eat the plant foods. Never eat omega-6 cooking oils. Avoid some of these other toxins. I've had previous lectures where I talk about all the different mitochondrial inhibitors, SERCA inhibitors, for example, and how aluminum can be toxic to the pancreas as well. So anyways, hope that was helpful.